topic tonight is going to be, as you can see on the screen, aquablation therapy for the man who is tired of BPH. So what we're going to do is learn a little bit about what BPH is and then what aquablation therapy is. We're very excited and thrilled to have this new technology here at CMH in Bolivar. We're between Arkansas and Kansas City. We're the only location to offer this cutting-edge technology right now. A little bit about myself. Again, my name is Dr. Mark Walterskirchen. I am a general urologist. I did my medical education at the University of Washington in Seattle and then did my residency at KU up the road in Kansas City. I am I guess you would say, a general urologist here in Bolivar. I do a wide range of urologic practice, anywhere from kidney stones to incontinence to implants, to cancer surgery, prostate, kidney, and the like, as well as a lot of treatment for BPH. As we'll learn, many men have that as a problem. I have no disclosures to report. And then today's presentation is going to be what is BPH, as I mentioned earlier, what are my treatment options, and more into that is how do I choose? Each case is unique and each patient is unique. And so finding what the best option is for you is key. Then we're going to discuss why I should consider this new technology, aquablation therapy, and then if we have time, we can hear from some real patient experiences. Understanding BPH. What is the prostate? That's a very good question. I sometimes equate the prostate somewhat to your appendix. We only talk about it when it's causing us problems. It does serve a function in terms of providing fluid for ejaculation during sexual intercourse, but beyond that, it just sits there and causes problems. And as we grow older, it gets bigger and bigger. It sits, as you can see on the diagram there, right below the bladder as the outlet to the bladder, so the urine has to travel right through it. And as we get older, BPH is the prostate growing. It gets bigger and bigger as we age, and by age 50, 50% of men have BPH, and each decade after that, the percentage goes up. So by the time you're 80 years of age, almost 90% of men will have BPH. Approximately 70% of each of those groups will have symptoms of that. So that's quite a large number. One thing to mention, though, is these symptoms do not indicate prostate cancer. People worry that BPH and symptoms of BPH equate to cancer. That is very rare. And we'll talk a little bit more about prostate cancer and how that differs, but it's very important to mention that is not the case. BPH is the enlargement of the transition zone. That's the inner part of the prostate. There are different sections, but the inner part is the part we're dealing with. I use the description quite a bit. My patients chuckle when I talk about this, that the prostate's kind of like a donut. And as we get older, the donut hole gets smaller. And so it gets harder to get the urine out. So we're trying to make that donut hole bigger one way or the other to allow men to empty better. The obstruction is an anatomical problem, meaning blocking it. So the treatment is an anatomical treatment. It's a very, very common, as I said, problem. Many men are treated for it each year. Approximately 12 million in the U.S. Men are treated each year for these symptoms. 40 million currently have problems with BPH. 6.7 million on this are being treated with medications, and those come with their own side effects and issues. Over 1 million drop out. They either don't tolerate the medications, they don't like taking pills, they're already taking enough as it is. I see that quite a bit in my patient population. Or they just quit working. So this leads us to approximately 400,000 surgeries every year for prostate issues. 83% of men are not willing to sacrifice sexual function for symptom relief, and that is one of the issues both with medications and the current surgical options that we have to balance in terms of treating this. What are the symptoms of BPH? And many of you, I'm sure, that are listening can list this off for me. It comes down to two aspects of voiding. One is the ability to hold the urine, the other is the ability to empty the bladder. The ability to hold can present with getting up at night, and this is a very, very common problem. Men get up 2, 3, 4, 5 times a night, and many times it can be due to other symptoms, folks that drink a little too much fluid in the evening, but it can be related definitely to the prostate. Going too often in the day. You go to the bathroom, get done, walk away, and got to go right back and go again. Urgency, that's a very common problem. As the bladder is filling up, it gets irritated trying to push the urine through this small donut hole. And so there's this constant need to go to the bathroom and get there very quickly. And in some cases, sometimes you don't make it. You'll leak some urine before you can get to that bathroom. In terms of emptying, the biggest complaint we'll see is it's a weak stream. You got a small donut hole, so you're going to have a small stream. It's going to take you a while to get empty. It's going to take you a while to get started. You may have to strain or compress your abdominal muscles to try to get those last drops out. Hesitancy, it takes you a while to get going, or intermittency, where it starts and stops and starts and stops. And then the ultimate symptom is where folks suddenly just can't pee. They're in misery, they can't get anything out, and they end up in the emergency room and have to have a catheter. 99% of men with BPH and symptoms say it affects their quality of life, and that's the goal, is to improve the quality of life. It's not the life you live, but the quality of life you live. The biggest issues we see is the disrupted sleep, getting up 3 or 4 times a night. You don't get quality sleep, and that affects your health in many other ways. It limits your activities. You may not want to go watch a ball game or go see a movie because you're up 2 or 3 times during the movie to go to the bathroom. And then, of course, there's the sexual dysfunction aspect of it. So how do we diagnose folks with BPH and kind of evaluate them for this? First thing, when folks come in to see us, we're going to talk to them and get some history. Find out, have they ever had issues with their prostate before? Some people come in and they've had procedures before, and that may lead us down to a different track. Some folks have issues with diabetes. I've had a couple patients that did not realize they had diabetes, and so their blood sugars were quite high, and that caused them to go to the bathroom quite a bit, both during the day and the night. So in that situation, it wasn't so much a prostate issue, but we'll ask those questions. We're going to do a good physical exam and check the prostate. Many men don't look forward to that, nor do I, but it's an important part of the exam. We're going to evaluate your symptoms. We very well, most likely, will also check the PSA test. This is the screening test for prostate cancer, and it's important to know that before we consider any other interventions. Again, these symptoms are not related to prostate cancer, but the goal is, if someone has it, prostate cancer, to pick it up before you do have symptoms. So that's where the simple blood test, or PSA, is important. As we get going along the line and we're discussing more of the options, we may get a little bit more involved in terms of the evaluation. One of the simplest tests we'll do in the office is an ultrasound of the bladder. We'll just do what's called a bladder scan. So my nurses will have you go to the bathroom, come back, and we'll just put a little ultrasound wand on your lower abdomen and measure how much urine is left behind. Most folks, it's not a lot, but in some folks that have severe prostate issues, they may leave 4 or 5, half a liter behind in their bladder. I had a gentleman just this week that he had 500 cc's in the bladder and did not realize it. So the body is an amazing thing. It learns to adapt. And unfortunately, in some cases, that's not such a good thing. The other thing we'll do is what's called the International Prostate Symptom Score. It's just a simple 7-question questionnaire that we ask you to fill out. There's no right or wrong answers, but it gives us a way, based on this score, to kind of quantify how bothered you are. It also allows us to quantify, visit to visit, how you're doing. If we start a medication and you come back in and your score is cut in half, or you've had a surgical procedure and your score is cut in half, that tells us that you're seeing improvement or you're not seeing improvement. So you can visit their website to take the questionnaire yourself, and if you haven't already had it somewhere, and kind of get an idea where you stand with all that. If we're looking then further down the road and we are considering some sort of intervention, we may consider some sort of imaging study, either an ultrasound or a CT scan, to get a better idea exactly how big the prostate is. And we also may even just look inside the prostate and the bladder to get an idea of what the inside looks. But again, it's a case by case. We work with you and share decision making as to what's going to be best for you. So BPH, or enlarged prostate, is a chronic disease with long-term consequences if not treated. As I mentioned before, the gentleman that was in my office this week with half a liter of urine in his bladder, that's not a healthy condition, because it leads to bladder damage. Over time, as your bladder is working hard to force that urine through that small donut hole, it's building up elasticity, and eventually the muscle in the bladder wall is replaced by fibrous tissue, so there's no muscle. So eventually, the bladder just quits working. I describe it to my patients as you go to a birthday party and they've got beautiful balloons blown up, and a week later you go back and the balloons are still up, you deflate them, they don't go down to their original size or shape. They stay really stretched out, floppy, and that's the case with bladders. And so it happens progressively over time that eventually the bladder just kind of quits working. And at that point in time, folks may need a long-term catheter to drain the bladder. Also, if you're not emptying well, it can lead to stones that build up in the bladder. These are not necessarily kidney stones, but stones that result from the urine just sitting there and crystallizing. Folks may see a lot of blood in their urine from this. It can lead to infections. If the urine is not draining out of the bladder and just sitting there like a little mud puddle, it's a great environment for bacteria. So folks that come to see me with recurrent bladder infections, one of the first things we're going to do is see, are they emptying their bladder and do they have any stones in there? Long term, like I said, this is a long-term issue. If the bladder is not draining, it can back up the urine into the kidneys and cause kidney damage. So that's another reason why this is something important to monitor and treat before it causes problems. A lot of times patients will come to me and say, when we're discussing their options, their comment is they're going to wait until it's absolutely necessary. Well, unfortunately, when it's absolutely necessary, sometimes that's too late and we've missed the boat. So the treatment options, every patient, as I mentioned, is unique, and there's working with each and every patient based on their symptoms and their size and their medical history and things like that. It's important to kind of come up with what the best plan is. So in some folks, if they're not overly bothered, we will do what's called watchful waiting. We may offer some behavior modifications. Folks that drink too much soda pop, coffee, or tea, try to get them to cut that down. May go a little less often. If they're diabetic, get a little bit better control. But potentially the bladder or the prostate will continue to grow and those symptoms will get worse. The next treatment line would be medical therapy, pills. There are essentially three options. The most common is what's called an alpha blocker, or the brand name is tamsulosin or Flomax that many people are familiar with. There are some other versions of that. What they do is they're relaxing the muscle in the prostate to open up, make that donor hole bigger. It doesn't necessarily matter the size of the prostate. They'll work. But again, as I said, a lot of folks are already taking a lot of medications when they come to me, and they really don't want to take another one. There are side effects such as dizziness, headache, fatigue, and some of the other ones such as finasteride can cause problems with sexual dysfunction. And again, over time, those drugs may quit working. So then we move on to the surgical options, and there is a laundry list of surgical options. If you get on Dr. Google and research this, you're going to find a long list of different options, and we're going to touch on some of them, and each kind of have their pros and cons. There's some that are minimally invasive that are very quick and easy and fast, but they have their downsides. The benefit is they tend to avoid some of the sexual side effects. However, their efficacy and long-term success are not great, and they're also very much limited by the size and the shape of the prostate. Also, you're trading off the benefit of the procedure versus the sexual side effects. So these what we call missed or minimally invasive surgical treatments, they get reasonable symptom relief, and they prioritize sexual function. These treatment options include things like Urolift, where we put little pins in the prostate to open it up. They're permanent, anywhere from 2 to 6 little pins. It's a very quick 5-minute procedure done in the office or the operating room. There's what's called iTind, a little metal basket we put in for 5 days to open it up. There is Steam, Resume, and all those, again, are minimally invasive, but they're very limited by the size and the shape of the prostate. The traditional surgical options tend to have better success rate in terms of being effective. However, they do have a broader range of sexual side effects and, in general, overall side effects in terms of continence, not leaking urine, and the ability to have erections as well as ejaculations. Some of these procedures result in what's called retrograde ejaculation. That's where with climax, things go backwards rather than forwards. For some folks, that's very important. Other folks, that is not important. So again, this is where it's important for us to sit down, talk, and individualize the treatment, what's going to be best for you. There's some statistics regarding the importance between the sexual function and the procedure. Bottom line is that most men, 99%, really feel that having problems voiding affects their quality of life. And again, that's where we get into what is going to be the best option for you. So this kind of leads us into the aquablation treatment. Like I said, we're very proud here at CMH in Bolivar to be one of the only facilities in the region to offer this option. It's a very unique and very special treatment options, it kind of manages both the efficacy of the treatment as well as the avoiding the sexual side effects. It's compared to the TURP. The TURP has been around for, as it says here, 100 years. It is the tried and true, what everything else is compared to. People refer to it as the Roto-Rooter or ream job, but we call it a TURP, transurethral resection of the prostate. This is where we go in with a scope through the penis, and we resect or cut out the inside of the prostate. We're not removing the whole prostate. As I tell folks, we're just making a bigger donor hole. It does have some higher rates of complications, such as scarring or stricturing. It does result in retrograde ejaculation, and over time the prostate can grow back. It also is using heat to treat this, and that heat can affect the nerves in and around the prostate that can affect continence and potency. It also is somewhat limited by the size. To talk about size, I have here my demonstration model. So this did not make it into dinner last night, but a little potato. But this is about a 50-gram prostate. The average prostate in most men as they're growing up is about 40 to 50 grams. So this is just a little bit larger. A large prostate, about 100 grams, is about that size. But what we're trying to do, as I mentioned, is make a bigger donor hole. So you can see here, tiny little donut hole, and that's after aquablation, nice big channel. So that's what our goal is to, and with aquablation, it doesn't matter the size of the potato, it just works on all of them. It's been around now since it was developed in 2013, FDA approval in 2018, Medicare approval in 2020, I believe. And so it's been studied. There have been 3 very important studies done to document. It's one thing to say that it works, it's another thing to prove it. And they've had 3 excellent studies documenting, 1, it's effective, 2, it's safe, and 3, it's efficient. It works on any size of the prostate. What it's doing is using and we're going to get into it here in just a second, a water jet, water pick, power washer that you use to wash your fence. So there's no heat involved. It's used to just ablate the tissue with this water jet, and it's using a robotics to steer it. And then we use computer-generated and artificial intelligence to map it out. So we know exactly what the tissue, where the tissue is and what we're using by ultrasound as we're doing it. Like I said, it's proven very safe and effective over these studies, the WATER 1, WATER 2, and WATER 3 trials. 99% of men preserved erectile and orgasmic function. 89% preserved their ability to ejaculate. And over 99%, basically almost 100%, did not have any issues with incontinence after this. And 94% at 5 years did not require any other therapy. And this is better than any and all other treatment options right now. So it's proven quite effective over the long haul. It's a game-changing robotic-assisted procedure that removes prostate tissue using the power of water. Again, there's no heat involved. It's real-time image guidance. So what we're doing is we're placing an ultrasound probe in the rear end. This is done in the operating room under an anesthetic, so folks are asleep. It takes less than an hour. But we use the ultrasound to map out the prostate. So we know exactly the size, the shape, what we're trying to remove, and also what we want to avoid in the prostate. It's personalized, meaning, again, each patient is unique and different. So we can map it out based on your anatomy. Robotic assisted in the sense that the water jet is attached to a camera that's placed through the urethra, and once the program is set up, the robot takes over and it just ablates the tissue. I just step on a foot pedal and it takes over. Folks worry that the robots are taking over in all aspects of our life, but what I tell folks, the robot is a tool. It is helping me. I am still in control. So you do not have to worry about the robot taking over. And again, the other benefit is this is heat-free. There is no heat involved with this water jet, so we're able to preserve and protect the important structures. It is the only ultrasound-guided, robotic-assisted, heat-free water jet for the treatment of BPH. So what we're looking at here is in the operating room. This is the screen that I'm looking at. We've got the ultrasound probe that is in the rectum. So the rectum is down here at the bottom of the screen. This is the bladder, the dark spot off to the left of the screen. And then right here, this is the prostate. You can see it nicely mapped out. What they've marked here, and this is what the computer is helping us do, is mark out where the ejaculatory ducts are for sexual function. And so we've blocked those out. And we can adjust this again based on these markers, based on each patient's anatomy. So once we get this all set up, I'll just kind of turn this on. We're kind of adjusting it, marking it, again, individualizing it to each patient. We mark there the location of the bladder neck, the sphincter, the lower aspect of the prostate, and then the apex of the prostate where the ejaculatory ducts are, and personalize it to each patient. Then once we get that all in position, then we turn on, like I said, the robot, and at the tip of this scope is going through the penis, and right here, halfway back is our camera, so I'm watching as this is going on. At the other end is the tip is the nozzle with the water jet. And again, this is all done, all the robotics on the inside, controlling this based on the personalized plan that we had mapped out with the computer. So then we turn on the water jet, and it is like going through a car wash. It's just sweeping back and forth, ablating that tissue. And you can kind of see there at the bottom of the screen how it's got, and we're going to get a scope view of the scope here in just a second, right there. So you can see the water jet. That's my view that I'm seeing as the procedure is going on. And it's quite quick. You can do a large prostate in a small amount of time. We're talking 10 minutes. And as this is going out, we're aspirating and sucking the fluid out of the bladder and that ablated tissue, so nothing's left behind. And then it gets to the apex of the prostate where the ejaculatory ducts are, and it automatically stops because it knows that's the area that we do not want to ablate. And more often than not, we'll go back and do a second quick ablation just to make sure we get all that tissue. But you can see it's doing a wonderful job just ablating the tissue that we specifically address and avoid the tissue that we intentionally want to avoid, so we can preserve that. So what to expect both before and after aquablation therapy. So you've been to my office, you've seen either myself or my assistant Jesse, and we've talked about the options. We've determined that you're a good candidate for it. We'll then schedule you for surgery. We normally do these on Wednesdays here at the main hospital at CMH in Bolivar. There are sometimes some more steps we have to go through. There's usually a pre-op visit. One of the more common questions we get is, what about folks that are on blood thinners? And that's an excellent question. Like any surgical procedure, particularly on the prostate, we have to have folks off of their blood thinners for a different period of time depending on which type of blood thinners you're on. There's Eliquis, there's Plavix, Coumadin, all those. And so we usually have to get permission from either your primary care or your cardiologist to stop them for a period of time, for a few days before and then a few days after, because that is certainly a risk of bleeding when you're on a blood thinner. But assuming we get that permission, then we can go ahead and get you scheduled. As I said, it's done at our main operating room under an anesthetic. Folks will go to sleep. Procedure start to finish out the room is less than an hour. Folks will wake up in our recovery room. We have an outstanding collection of nurses in our recovery room that's very experienced with this. There'll be a couple big bags of fluid hanging over you connected to the catheter that I put in the bladder after the procedure. This is to irrigate continuously to make sure that there's no blood clots forming. We will then transfer you out to our floor. We have, again, wonderful collection of nurses that are very experienced with this on our floor. Great staff, great hospital. They're very caring. They're wonderful. That's one comment I get from many of my patients. I have folks that travel from all over Springfield, and that's the one comment we get quite often compared to a lot of the hospitals, is just the care and the wonderful folks that we have working here. That and the cashew chicken for dinner, I strongly recommend that. But we'll watch you overnight. The next morning, I generally will make my rounds bright and early at 6:30, and we'll have turned off the irrigation. If the urine looks clear, most folks, I will personally remove my catheter at 6:30 that morning. We'll get you up moving around, walking, and if you're able to void and your urine stays relatively clear, usually about lunchtime, we're sending you on your way. There are some places that will do this and send folks home the same day. We're rural here, so I have folks that travel a long distance, so I prefer to watch them overnight as a precaution. And like I said, most folks will leave the next day without a catheter. Certain instances, we may send you home with one for a few days. After the catheter is removed, I warn folks the first 1 to 3 weeks, I may not be your favorite person. There is going to be some stinging, burning, while the prostate's healing, as well as you may have a sense of increased need to go often and urgently, and you're wondering, why the heck did I go through this if that's the symptom I was trying to get rid of? Well, your bladder's been working so hard to get that urine through that small donor hole, and now all of a sudden it's got a massive donor hole. So it's learning to compensate for that, and it will. The bladder's a smart organ, it will learn, and so within 2 to 3 weeks, all of that will settle down. You may experience blood in the urine as well for weeks after this, so don't be alarmed about that. That's certainly expected. But in terms of getting back to normal day-to-day activities, whether it's doing yard work, mowing the lawn, getting on your tractor, we usually say 1 to 2 weeks with that. It's mostly just not to stir up any bleeding. It's not that you'd hurt yourself. And then we have you usually come back and visit us about 3 weeks after the procedure, and then a month or two after that as well, just to make sure everything's well. The goal of this as well is to get you off your prostate medications, whether it's the tamsulosin, finasteride, or both, and that's our goal. At the time of discharge, we will stop those medications. So the journey, taking the next step. So as I said, there are different options in terms of getting to this point. There is, if you're not overly bothered, like I said, this is a quality of life decision. If you're managing and getting along just fine, and we've shown that you're not leaving a lot of urine in your bladder, we can just continue to watch it. But if you're bothered, you're tired of taking medications, or they're not working well, aquablation may be an outstanding option for you. But that's kind of my presentation this evening. We're more than happy. I don't know if we have online questions, but certainly if you're interested in learning more about this for an in-person visit, you're welcome to call us at that number. My team, led by Vicki, is outstanding at getting you in and answering your questions and seeing what we can do to help you. So, do we have to have a referral? Yes, we do. That's a good question. But most folks are very good about that. And like I said, we're the only facility between here at Northwest Arkansas and Kansas City that is offering this currently. So Springfield doesn't have it. Joplin, Rolla, we're it. So we're very excited about that and very appreciative for CMH for their support for this state-of-the-art care that we offer here. So how does this compare to lasers? And that's a very good question. There are quite a few different laser, I'll use the laser air quotes, laser ablation, KTP laser ablation has been around 10, 15 years at least. And that is where you're using a side-firing laser to basically ablate the tissue. But you're doing that visually. You have no idea how deep it's going or how much tissue. And it's fairly labor intensive. It also is very irritating. To be honest, I did it initially, and I just wasn't satisfied with the results. People were not very happy with the results, and I had a number of folks that ended up just getting a TURP because they were miserable with it. So there are some newer options with laser. There's what's called HOLAP. So it's called holmium excision of the prostate, and it's where they go in and they get into the plane of that. I was talking about the transition zone, the inner part of the prostate, and they get in that plane and just dissect it out with the laser. Then they push the adenoma, what we call, or the gland that's left, that's been cut out, into the bladder, and then they got to chop it up to get it out of there. And it's a good option, but it's a very difficult procedure to learn. I was interested in it, but it's a university type setting. There are some big community hospitals that do it, like in Kansas City, but it's a very difficult procedure to learn. I think they get great results. It's just, you got to find somebody that's all they do, and they do it well. It's not something you want to do part-time. Another treatment option that's been getting a lot of press that I'll mention as well is what's called prostatic artery embolization. This is a non-surgical procedure. It's a procedure that's actually not even done by urology. It's done by an interventional radiologist. They are folks that stick needles into things. So the interventional radiologist basically goes into your groin, kind of like if you're having a heart catheterization. But what they're doing is they're going down to locate the artery going to the prostate, and then they cut off the blood supply to the prostate to strangle the blood supply and get the prostate to shrink to hopefully get it out of the way. I don't know a whole lot about it because there's really nobody around here that does it. Again, it's a very technical procedure. I know early on they had some issues with blocking the wrong arteries and getting some complications. I think they've gotten away from that. The issue can be that there are not just always one artery to the prostate, there can be others. So you may knock off one artery, but you may miss another, and so the prostate continues to grow. But I know they've had good results, and in some places they're doing quite a bit of it. I'm just not that familiar with it. And I don't know the limitations. I think there is a size limitation on it in terms of how big the prostate, as opposed to aquablation. Basically, you can do almost any size prostate, any shape. Well, I appreciate everyone. Those were wonderful questions. Hopefully this was beneficial to you. You've got my number there. We're more than happy to get you set up here in Bolivar at CMH and get you taken care of. So please don't hesitate to give us a call, and you all have a wonderful evening. Good night.